So starting off, our paper was effects of tranexamic acid on death, disability, vascular occlusive events, and other morbidities in patients with acute TBI. Um, and I'm Mehwish Khan, MS3, and my partner can also introduce himself.
Hey everyone, can you guys hear me? I'm Jeffrey Henson. I'm also an MS3. I'm a med student at the University of Arkansas for Medical Sciences here in Little Rock. So to begin, just to give everyone a synopsis and a background overview, the CRASH 3 trial was a placebo-controlled randomized trial in which the effects of tranexamic acid use were investigated on death and disability in patients who experienced acute traumatic brain injury. So previous evidence from a trial, the CRASH 2 trial, showed that the use of tranexamic acid within 3 hours of TBI injury might reduce death and overall morbidity and mortality from traumatic intracranial bleeding. And also a meta-analysis of two previous small randomized trials showed a significant reduction in these two primary outcomes with the use of tranexamic acid, yet they had a very small overall sample size of only around 510 patients. So the thought behind conducting the CRASH 3 trial was that it was undertaken to provide a larger data set with a large enough sample size for appropriate statistical power to have proper investigation of these effects. So the primary outcomes regarding this study that were investigated was head injury death in the hospital within 28 days of injury in patients who were either randomly assigned to receive tranexamic acid or placebo within 3 hours of their injury. And the secondary outcomes that were investigated were overall head injury related within 24 hours post-injury, all cause and cause-specific mortality, as well as disability, vascular occlusive events, seizures, other complications, neurosurgery, days in ICUs, and other adverse events within 28 days. Okay, and so just for a little bit of background information, each year worldwide, there are approximately 60 million new cases of TBI, with road traffic crashes and falls being the two most common etiologies, and the incidence is increasing. Intracranial bleeding is a very common complication of TBI, and it increases the risk of death and disability. Although bleeding can start from the moment of impact, it often continues for several hours after the injury, and ongoing intracranial bleeding can lead to raised ICP, brain herniation, and death. So tranexamic acid, as a medication to treat intracranial bleeding, acts as an antifibrinolytic agent. What it does is it acts to prevent the activation of plasminogen to plasmin, thereby preventing the degradation of fibrinolytic clots. And it does so and promotes hemostasis. It has been shown previously to decrease surgical bleeding and traumatic external bleeding, and decreases mortality in subsets of these patients. So for researchers for this study hypothesized that maybe the use of tranexamic acid could also decrease intracranial bleeding that was seen in traumatic TBI. So for inclusion and exclusion criteria for this study, adults who experienced TBI and presented within 3 hours were included. They had to have a GCS score of less than 12, as well as any evidence. An inclusion criteria was any evidence of intracranial bleeding shown on head CT, and an exclusion criteria was that if they had any evidence of major extracranial bleeds.
Okay, so for the method portion, right? So this was a double-blinded, randomized, placebo-controlled trial. It was international, so it was conducted in about 29 countries, and the sample size was pretty large with 12,737 patients. Both placebo groups and intervention group were about 6,000 patients, and all were treated within 3 hours of injury. So for the experimental group, they got the 1 gram of tranexamic acid infused over the first 10 minutes and then over IV for 8 hours. And for the placebo group, they just received 0.9% sodium chloride saline instead of the tranexamic acid. And the researchers collected this data for 28 days after receiving treatment or discharge or at death. So patient characteristics. So we can see that both intervention and placebo groups had similar proportions with fairly even age ranges as well as time to injuries and blood pressures and GCS scores as well. So intention to treat, right? So the effects of the tranexamic acid was analyzed by recording disability, vaso-occlusive events, and other complications at varying times of treatment. So when you had, there were 2 treatment groups where you had less than 3 hours and then greater than 3 hours. And outcomes were also further than subdivided into categories of severity of head injury. So with GCS score 9 to 15, mild to moderate, and 3 to 8, severe. And also looking at pupil reactivity with reactive pupils bilaterally or any unreactive pupil. And then they excluded patients with a GCS of 3 and unreactive pupils when analyzing the data. And for each outcome, they looked at the relative risk and a 95% confidence interval.
Okay, so for the results, so as you can see, I've included the primary results here. A lot of the results for the secondary outcomes did not show any significant differences between our treatment group and the placebo group. Almost all of the relative risks were close to 1 for each secondary outcome, as well as the confidence intervals being inclusive of 1. So for the primary results being that of mortality, between the tranexamic acid and placebo groups, they sub-stratified each group based on GCS scoring, either being mild to moderate being GCS of 9 to 15 or severe being 3 to 8. As you can see for that substratification, the significant results that were found was that treatment with tranexamic acid in the mild to moderate group had significant decrease in mortality with a relative risk of 0.78 and a confidence interval of 0.64 to 0.95. For the severe GCS group, there was no significant differences found, as well as for pupil reactivity. For pupils, where both pupils reacted, they did observe a significant improvement or significant decrease in mortality with a relative risk of 0.87. As you can see, for pupil reactivity in the group where pupils were not reactive, you do not see a significant risk. And the overall, the relative risk between the 2 groups was not significant. I'm sorry, that was for this graph as well. For the figure on the top right, you can see the mild to moderate GCS score and the severe GCS score. The results were analyzed as time to treatment for each group. Time to treatment for the mild to moderate group showed a significant decrease in mortality with earlier intervention, and it increased almost linearly as time to treatment increased. For the severe GCS score, there was no correlation that was found. So irregardless of when treatment intervention was initiated, there was no improvement in outcomes. And the graph here on the bottom is just an overall view of all previous evidence related to outcomes in tranexamic acid use. The CRASH-2 trial showing a significantly reduced mortality with the use associated with tranexamic acid as compared to placebo, as well as another trial. And new evidence proposed by this trial shows the same. So all of the results over time have been relatively consistent in showing that tranexamic acid is favorable for treating preventing intracranial bleeds associated with acute TBI.
Okay. So conclusion-wise, we saw that tranexamic acid was seen with mild to moderate brain injury to decrease death when given within 3 hours of injury. And then when data was also stratified from time to treat, there was no reduction or increase in disability, vaso-occlusive events, or other complications. So the benefit of tranexamic acid is dependent on two main factors: early treatment, um, with and as well as mild to moderate GCS scores. Right, earlier the treatment, the better the outcomes, and no correlation in effects of time to treatment on improved outcomes in patients with GCS greater than or equal to 9. And then we also saw, right, GCS 9 to 15 moderate had the best outcomes seen, with a relative risk of 0.78 and with confidence interval 0.64 to 0.95. And tranexamic acid is most effective in reducing early intracranial bleeding, expansion, preventing devastating neurologic sequelae, and later to treat interventions confer no benefit as extent of damage due to intracranial hemorrhage cannot be overcome just by pharmacological intervention. And also to note that overall, the study did have a higher mortality rate, with the intervention group having a mortality rate of 18.5%, and the placebo group had a mortality rate of 19.8%. So overall, we can see that there's no harm in giving the tranexamic acid earlier, right? Because we saw no increase in adverse events, but also not really a decrease. So if you have a moderate GCS and you give it early on within 3 hours, it can be beneficial.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.